Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing a case of an young middle-aged female who presented to our ER with complaints of decreased response. Can we begin, sir?
Yes.
A 50-year-old female was brought to the ER with complaints of decreased response that morning at around 5 o'clock. So in our initial 10-second...
response to motor stimuli or sensory?
Sorry, sir?
Decreased response
Sensorium, sir.
Altered sensorium.
Altered sensorium.
Altered sensorium.
Decreased response, sir. Right. Response as in sensorium was low.
So response is only sensory response, motor response, sensory.
No,
you have to be very precise.
GCS, sir.
Altered
Sensorium. That's right, sir. So she was brought with that complaint, and in our initial 10-second assessment, patient was only responsive to pain. So quickly moving on to the airway primary survey, airway was patent, as there was no anatomical deformity, no pooling of secretions were there, and no snoring or fallback of the tongue was noted. And breathing wise, patient had a circulation respiratory rate of 18 cycles per minute, maintaining saturation of 98% in room air. Bilaterally, air entry was equal and chest was clear. So aspiration was ruled out at this point in time. With moving on to the circulation wise, patient had a heart rate
at this juncture, you want to do anything? What was the GCS?
GCS was even V3M5, sir.
So you think the airway is okay?
Since patient saturation was maintaining and there was no snoring or anything, we didn't really go for OPA or NPA.
See, with the GCS of 8, somebody is coming with decreased response, what will be your first priority is to secure the airway.
Okay, sir.
So whatever be the reason, you have to secure the airway, and simultaneously you need to go ahead with the breathing and circulation and your GRBS, whether it's a simple hypoglycemia, you need to rule out. So that's the first thing that you need to look into. So when we say vertical survey, or you need to go ahead with an horizontal survey, the same point of time, and you should be prepared for an RSI at this point of time. If it is not a hypoglycemia, then there is something happening intracranially. So we need to go ahead and secure the airway. Okay, that is as an emergency position, that will be our priority one. Then only the next things will come. So once you stabilize the airway, then you go for B, C and D. Simultaneously, it will all happen. So when we are presenting like A, B, C, D, we are presenting. But we are doing it all together.
Yes, sir.
So you would have done an breathing assessment, and chest entry, air entry was bilaterally equal. Then the next thing, circulation. There was no evidence of hypotension. Hypertension was there?
170 or 130 was
so that is hypertension.
Yeah, that's right.
Heart rate?
76 beats per minute.
76 beats per minute. So there is no much bradycardia, but there is hypertension. So you have a patient with altered mental status with hypertension. You don't have the classical Cushing's reflex. You have hypertension. Maybe the later bradycardia can set in. So probably we are dealing with an intracranial pathology. Either it's an hemorrhagic or a stroke. We are not very sure. Some intracranial acute pathology we are dealing with. It's an acute presentation.
Yes, sir.
So that's it. So disability, you said the GCS. What is the pupil?
1.5 millimeters bilaterally and symmetrically reactive to light.
Similarly reactive to light. GRBS?
GRBS 140 milligram per deciliter.
So we have ruled out.
Febrile.
So we have ruled out an hypoglycemia, which is the most important differential diagnosis at this point of time. So our priority here, secure the airway. Before the patient is moving out to the ER, whether you need to, the next thing you will be sending her for an imaging. So the next thing, you have to secure the airway and send her to the imaging. So how will you manage the airway here? Sir?
Yes, correct.
Anything, sir?
No, that's correct. See, one of the indication for an endotracheal intubation RSI is
8 or less than 8 GCS.
And even, say, one more thing, in breathing, you have to tell about the ventilatory excursions. See, what is adequately chest is rising and falling. So patient may be breathing, maybe tidal exertion may be very poor.
Yes, sir.
Okay, so that you have to mention.
Maybe a gasping breath also, that at the time the saturation may be maintained, but that's not a normal breathing. So you have to exactly take what is the breathing pattern. Maybe you have a waxing and waning type of breathing. You have the classical Bitorts breathing, chain strokes breathing, all those things you need to be more specific. Maybe in the initial phase you can wait, but later on when you are describing that, then you need to be very specific regarding the type of breathing.
So this patient had adequate chest excursions. She was not gasping either. So also
so we have to go ahead with an adjunct here. That is the first thing. You secure the airway. With what all measures you will secure the airway here?
So, sir, in this patient, once the consent is taken and RSI has been planned, we do keep in mind raised intracranial pressure as one of the DDs because of raised intracranial bleed. So, in this case, all the drugs that increase blood pressure, ICT will not be used. Like ketamine will.
Ketamine is again theoretical. There is no, right now ketamine can be given, but for this patient we will not be selecting ketamine because blood pressure is already on the higher side. We don't want it to increase further. So ketamine we will not be using, not because of raised ICP. We are not interested, but what will be the ideal drug?
Propofol would be an ideal drug, sir. Apart from propofol, etomidate can also be used.
Before going to that, as two aspects you got to see history. So at least bare minimum history, whether there is any comorbidity is present or not. Especially whether the patient is having any hypertension, is on any drug continuously taking, including beta blockers.
Okay, sir.
And also any ischemic heart disease, any drugs patient is on.
When talking about that, sir, patient
Number
is.
two, RSI, whenever you plan, first thing you have to rule out is any difficult airway. Airway assessment is also most important.
So the emergency room, how quickly you can do an airway assessment? You can't do the classical Lemon assessment. It is very Malambati for this patient. You can't assess. She's bearing, opening her mouth. So how can you assess the patient's
Sir, in
airway?
this patient, we look for the general physique of the patient. If the patient has a short neck, or patient is obese, or patient has like small mandible or any anatomical deformity, all that part we will see.
Okay, maybe you can just check for the 332 rule that we can just try to assess. Maybe the first part will be difficult, the rest things you can assess. And you can have a brief idea regarding the how difficult the airway it is going to be. And you need to be prepared for all your difficult airway kit. Everything should be ready. Your adjuncts, what all things you needed for an intubation, your gum elastic bougie, maybe a video laryngoscope if you anticipating a short neck and a difficult airway. All those things should be kept ready. And supraglottic airway devices also can be. Here the patient is actually breathing well, only to secure the airway, but definitely she needs an definitive airway. That is a cuffed tube inside the trachea. Supraglottic will not be an ideal choice. You need to have a definitive airway. So the drug selection, as you said, propofol. Your comments on it, sir? Propofol.
See, that's why suppose the patient is already before coming, he is taking some antihypertension. So the action plus propofol, it will cause profound falling. So either etomidate or propofol.
Propofol.
See, propofol, then any other drug, sir.
Thio. For induction agents.
Along with that.
As a muscle relaxant, you're asking, sir?
Propofol is not having any pain relief.
Analgesic properties.
Analgesia would be a fentanyl. Pain management. So it will be a pre-medication wise, fentanyl can be used at a dosage of 0.1 microgram per kg.
By fentanyl, then you give the induction.
Induction agents.
And especially when you suspect a raised intracranial pressure, we should at any cost avoid any further increase in intracranial pressure.
So since you asked, patient is a known case of hypertension but is not compliant on any drugs. So she's not really been taking her antihypertensives for a long time. And also apart from decreased response, when the bystanders noticed her, they also noticed a seizure-like activity in this patient. So it was a suspected seizure along with decreased response, and the patient was brought here with this background.
So with the history, there is some intracranial bleed. That is a differential diagnosis. Unless proven otherwise, some intracranial bleed has happened to this patient. Whether it is subdural or a benign parenchymal, whether it is subarachnoid, some raised ICP and there is a seizure episode. So it's an acute event. So unlikely to be an ischemic stroke, more likely to be an hemorrhagic stroke. That is a clue that we'll have. And you went ahead with RSI for this patient at this point of time?
Actually, we kept this patient on a monitoring because even V3M5 told up to 9 on 15. So we had RSI prepared, but we didn't go ahead with intubation because we wanted to observe the patient. Any further drop in GCS, then we would have planned, because this patient could have very well been in the postictal phase also.
Okay, so she just wanted to give that benefit out of the patient, so you observe, because anytime we can go ahead and do an RSI. And she was being continuously be monitored. But if it is 8 and less than 8, it's always better to go ahead. It's 9 is maybe a borderline GCS, but postictal is one thing that we can have a consideration. But definitely she needs an RSI. You should not be running around when that is needed. So you should be prepared for an RSI. That is the most important thing in this.
Not establishing an airway is important.
Yes, sir.
Protection of the airway is most important. See, it is sudden bout of vomiting. So before you go for an RSA, the patient will go for asphyxia, airway obstruction, sudden hypoxia, hypercarbia. Everything will further worsen the intracranial pressure. Okay, so you are better.
So
And what is the baseline of the patient?
Baseline was she was conscious, oriented, talking, obeying commands, no issues with her. Sir.
sudden onset or out of sensory?
Sudden onset. Like basically, she was last seen normal the previous night after dinner. She went to bed. At the morning at around 5 o'clock,
This event happened.
this event occurred.
Okay. Okay, so what was done for her after this?
So we prepared for RSI, although we didn't really go ahead with it. Then as a primary adjunct, we took an ABG to even rule out hypoxia too. This patient did not have a hypoxia, but patient had type 2 respiratory failure. Her pH was 7.22 with a PCO2 of
Hypoxia, how do
61.
you assess the hypoxia? There is no hypoxia.
We see the saturation and then the PaO2 will be on the ABG. Will have a PaO2, sir.
ABG?
Yeah, we did an ABG, sir. In
It's
this
an
patient.
ABG, arterial blood case.
Yeah.
What was the PO2?
72.4.
72.4 is a borderline PO2. She can be hypoxic at any point of time. Right now, there is no hypoxia, but her PCO2 has built up.
61.
So definitely she should be intubated, or it can be a post-ictal phase that might improve. But 7.22 pH, that is the time. I think we should not be waiting anything more. We should be going ahead and intubating this patient at this point of time. 7.22 pH with a PCO2 of what was the pH? PCO2?
61, sir.
61. Definitely there is no underlying COPD. This patient should be intubated unless and until somebody has given a drug from outside, whether they have given some benzodiazepines, and because of that benzodiazepine she is having this. You can wait and watch, but otherwise 7.2 pH, it's not wait for further, because sensorium is also low and pH is also worsening. Go ahead and intubate this patient.
So ration PCO2, what does it denote?
I didn't get you, sir.
SpO2, what does it denote? ETCO2, what does it denote?
Sir, SpO2 says us oxygen that is saturated in the blood.
Oxygenation.
So oxygenation of the
Can
blood.
assess with the-
PCO2 tells the
Ventilation
part.
parts.
So that's why ventilatory excursion, if you are examining, hypoventilation means naturally there is
PCO2
maybe
will
because
build
of
up.
the bleed or any other cause, drugs or something. So the most important when you are assessing ABC, B should be properly assessed.
Okay, sir.
Don't take with the SpO2 is normal, then there is no
Point.
this is like that. Concurrently, it has to go along with the either PaCO2 or ETCO2.
ETCO2.
ETCO2. Okay, sir.
Okay, so CT was taken for this patient.
CT was taken, sir. CT showed diffuse SCH,
Diffuse subarachnoid hemorrhage.
including the basal cisterns, sylvian fissure. So it was like a diffuse SCH, but there weren't any specific aneurysmal rupture points as such.
So how frequently you will see a seizure with an SAH?
It's quite common, sir. Whenever you have SAH and bleeding is there, patient will have hyper.
It's more very frequent. It can have seizure, but when you see parenchymal bleeds, will have more chances of having seizures,
Hyperseizures.
because again it's in the subarachnoid spaces. Usually they might not have this seizure, but unless and until you have a raised ICP or an brain parenchymal irritation, they will have a seizure. But when you see classically seizure, it will be more in terms of an parenchymal hemorrhage,
Cerebral.
more in terms of a cerebral parenchymal hemorrhage. So we thought of an intracranial pathology, we are finding an intracranial pathology at this point of time. Now we have feel that you have went ahead and intubated this patient, or you just continued?
No, sir. We did intubate this patient on a later time.
Okay.
Now,
So
how did you take the CT? CT was brought by the patient or you took the CT here?
No, we took the CT here,
So
sir.
without intubation, send
Yes,
the
sir.
patient for CT.
Yeah, on continuous monitoring we did along with the.
question of monitoring at all. On the way, what will you do? So you have got every facility. See, CT is one of the investigative procedures in such cases, electrical intubation and mechanical ventilation. Don't take the patient.
patient to CT,
You are
because
not stabilizing the patient yet. Okay.
here the problem, no, you are taking the patient out of your comfort zone. That's one thing. You're taking him out of your CT room. Something happening in the CT room, you will not be prepared, equipped well to handle a situation there. And he can vomit suddenly and have a bradycardia, and he can have a cardiac arrest. So that is not what we wanted. We wanted to prevent an event. So prevention of event, this patient prior to going for a CT ideally should have been intubated, unless and until you have a very close proximity or you have a portable CT, you are in front of this thing is happening, then you can think of all those things, but it is not ideal. Our job is to stabilize the patient. Here this patient's airway as per the GCS is low, and as per the ventilation parameters is also low. So the only thing that is maintaining against is oxygenation, but that can go wrong at any point of time. So there is no point in waiting in this patient. You should have intubated and sent to CT. Luckily for the patient, nothing has happened, and you have found out the diagnosis as a subarachnoid hemorrhage. Now, since you have confirmed a diagnosis of subarachnoid hemorrhage, as in the patient coming back to the CT room, he is in front of you in the ED. So, what are the parameters that you will be doing? Assessing the parameters, you will be reassessing the vitals. But what all medications? What are the basic things that you will be doing at this point?
Okay, so once the patient has returned from the CT room, we will recheck all the vitals, the hemodynamic status of the patient, and second, we will check for pupils, if at all pupil in any way,
pupillary asymmetry, GCS we will do.
GCS, all that assessment.
So we have confirmed that it is a raised ICP. You have a BP of 170 over 130, and you have a patient with a heart rate of 76 beats per minute. So what are the things that you need to tackle at this point of time? You are seeing an hemorrhage in the CT. Subarachnoid hemorrhage.
So, sir, since there's a raised ICT and already has had a previous episode of seizure, the likelihood of him having another seizure is too high.
See, just come with the A, B, C. Just stabilize the airway. You have not intubated this patient. Intubate this patient, because you are finding a pathology that will have a global effect on the brain. So go ahead and intubate. Take care of his ventilation. Then come to the circulation. There is a hypertension. You need to tackle that hypertension. So how will you tackle that hypertension?
So once we will repeat the whole primary survey again, sir.
We have done. I am telling you, the BP is still on the higher side.
So in this case, we will go ahead with IV labetalol.
Okay.
We will give in bolus doses of either 10 mg or 20 mg, and then we will keep checking the BP every 15 minutes. Now, after bolus doses, also the patient's BP does not come down. We'll start with infusion.
Okay.
At 1 mg per minute or 2 mg per minute.
So that is your hypertension management. Now we have to come for the specific management for the raised ICP. So what are the things that you will do for your raised ICP?
One will be pain management, sir. So, and we will not like injections and all that will reduce any kind of pain to that patient. Plus, we will give that 30-degree head end elevation.
Head end elevation. Avoid. You have 3-tier system. You can remember for the raised ICP management. First tier is all the primary things. Keep the head end elevated. Avoid compression over here. Jugular, internal jugular. So if you are intubating, don't tie a tight knot over your jugulars. So that will again decrease the perfusion, decrease the venous return. So that should not be done. So that again it raises the intracranial pressure. So our concern here is to decrease the ICP. So ICP decreasing agents like
osmotic diuretic,
mannitol. I don't think there is any role at this point, unless and until you have a pupillary symmetry or patient is finding an impending coning, you have to give mannitol, and there is no role for steroid also. So the agents that you can give is hypertonic saline. And maybe the patient is already on a ventilator, so you can continue the patient on a ventilator. And unless and until you are planning for a surgery, or the patient is an evidence of coning, only the role of your hyperventilation comes. That too, normal PCO2, lower level of normal PCO2, that is our target. So 30 to 35 will be our target. So that will be a raised ICP and seizure prophylaxis. Obviously, yes for this patient, because you have already visualized a seizure. There has been a history given by the family. So we have to give seizure prophylaxis. So raised ICP management is our priority, and definitely treatment and role of nimodipine. Since it being a subarachnoid hemorrhage.
Nimodipine is one antihypertensive, but the other major effect of nimodipine is that it causes vasoconstriction and prevents further bleeding. So if at all patient has a non-traumatic SCH, nimodipine 60 mg has to be given perorally or via RT. Then, like you said, sir, hypertonic saline has to be started. And since this patient has had an episode of seizure, because of that, we give seizure prophylaxis of.
So routine SIH, when you look into the literature, they are not recommendation. But this patient had a witness seizure, definitely yes. So raised ICP management, then deeper sedation, and maybe an surgery, very early surgery if the patient still have evidence of maybe you need to do the clipping early itself, or you need to decrease the decompression, or all those things you need to keep in mind. The next important thing that you need to have in your mind is how will you investigate further, whether it is you need a CT angiogram or a digital subtraction angiography. What is the reason for the hemorrhage? whether it's an aneurysmal or an AV malformation. So that will be a rough idea. But our initial as an ED physician, our aim is to stabilize the airway breathing circulation, which I think we had delayed in the airway. That to my feeling, whatever discussion what we had, we should have done earlier intubation rather than a delayed intubation, because anyway this patient is not going to improve immediately. So definitely doesn't look like a seizure activity. What was the lactate?
4.7.
4.7. So there was some seizure before also. Okay, that was the reason why you delayed the intubation. But again, the patient didn't improve. So again, and hypercarbia was there, and there was evidence of raised ICP. So there is no point in delaying in intubation in this patient, sir. Anything, sir?
What is the effect of hypercarbia on intracranial pressure?
It causes vasodilatation.
Dilatation.
Vasodilatation.
Cerebral blood flow will be
Increased.
That will cause further
raised in ICP.
So when you see the value of the carbon dioxide, arterial carbon dioxide, 60 itself.
It's high.
So further increase we could have
Avoided.
If you are mechanically ventilating and in necessary
Controlling the intubation.
Hyperventilation.
Yes, sir.
So you could have
Avoided.
See, by the time you take the patient to CT coming, minimum it will take half an hour.
What happened to this patient?
So when this patient came in, all the measures were taken, sir. Then the patient was taken for an immediate procedure right away.
Right away they took for the procedure.
So the patient was not in the ER for long.
So that is a definitive treatment they have gone at, and because there is a very high chance of this patient going into coning, so they just took for the direct procedure.
So, sir, literature says that even if CT is negative, but there's a strong suspicion for SAH, we do go ahead and do an LP.
LP, yeah, the xanthochromia and all those things. You can look at.
Or increased in the RBC.
Subarachnoid hemorrhage is you can diagnose it either with your history, CT or LP.
And this is also called as an Ottawa rule. Sir.
Ottawa rule.
Ottawa rule also has again another rule that we look for around 6 features and find out if the patient has an SAH or not.
Fine. Okay, sir. Okay.
See, sudden hemorrhage, what is the etiology? What are the precipitating factors?
Hypertensive emergency can lead to IC bleed, or trauma itself can lead to
What is the vascular
IC.
nature? Any pathology?
AV malformations can cause aneurysms or any tumor that has like
Bleed into the tumor.
Bleed into the
Sudden
tumor.
rupture may be because of
Stress, exertion,
stress, exertion,
cough.
any strenuous activities.
Yes, sir.
Okay, fine.
Thank you, sir.
Thank you.
Okay.